Hello, this is Angelia, and you're listening to or watching the podcast, Why You Do What You Do. The podcast that talks about human development and psychology to help you maybe figure out a little bit more about why you do what you do. Last time we were talking about the validity of the disease model, which, back in the day, that's how it started out. These doctors and, people in the late 1800s assumed mental illnesses had a physical component to them, which some of them do, but not all of them do. So that's where they started out, and we're going to talk a little bit more about that. It would be equally hard to overestimate the influence of the disease model on approaching abnormal behavior. The model largely responsible for placing abnormal psychology within the jurisdiction of general medicine. The popular psychoanalytical theory posed by Freud changed the emphasis of that perspective from the body in general to the mind in particular, because they realized not everything that's going on up here has a physical component to it. Sometimes there's just problems up there. So the mind is but the underlying conviction of an organic cause was still indicated by the requirement maintained today that psychiatrists first obtain a medical degree and then specialize in mental disease, the way dermatologists specialize in diseases of the skin or ophthalmologists in disorders of the eye. And of course, now we know that psychiatrists are the ones who can treat mental illness and prescribe medication for that. So, they do have to become a doctor first. Now, psychologists do study. When I was studying, I took a course on the structures of the brain, the physiology of the brain, and I did take one medical course. So, psychologists don't have to become a medical doctor first, so that's the difference between those two. This bias toward a medical viewpoint brings up two rather controversial questions. Number one, is the disease model truly valid for understanding psychopathology? And in some cases, it's not. Number two, should the diagnosis and treatment of abnormal behavior be the more or less exclusive province of medicine? And I'm just going to say it shouldn't be. Psychiatrists have their place, and I think sometimes psychologists can send a patient to a psychiatrist if he thinks some medical intervention would be helpful. But what psychologists study is strictly psychology, the structure of the brain, the physiology of how that interacts with your body, and mental illnesses, the problems, how your mind works, how it develops as a human being, and the problems that can come in with that. So they're overlapping set of professionals, but they do have two different takes on things. Like I said, I always recommend that somebody go to a counselor or a psychotherapist first, and then you can be referred to a psychiatrist if there's a mental and physical component in play, which in some cases there are. These two issues are not a direct result of the DSM alone. As we noted, the disease model received wide approval long before DSM-1 was first developed in 1952, because that's all they knew back then. That's what they thought, it was all about. But the different versions of this classification system, especially the most recent, represent an approach that enlarges the role of medicine. And, like I say, they realize that, not everything has a physical component. Sometimes there's mental problems that have to do with the way, you came up, and things that happen to you can derail the train, so to speak. Sometimes it has no physical component. The term mental illness reinforces the impression that abnormal behavior is a medical problem. And like we say, it's not always. It must be handled by a mental specialist, of course, but it is still a medical illness. However, In physiological illness, there is always some underlying organic malfunction to account for the behavior that the ill person exhibits. And of course, we know that's not the case anymore. It's what they thought, back in, let's see, what was that? They were quoting 1952. So, even as recently as that, that was the take on that. Thus, when a child with a high fever complains of a very sore throat, it is highly possible that Streptococcus bacteria will be found in a microscopic examination of the throat culture, a condition commonly called strep throat. So, my kids have had strep throat. I've had strep throat. But again, with mental problems, it's not always that cut and dry. Unfortunately, the same formula cannot be applied to mental disorders because there is no such corroborating physiological evidence. True, there is research showing some clear links between certain forms of abnormal behavior and would appear to be breakdowns in the neurological functioning of the brain. And that's where you get things like dementia, Alzheimer's, where the actual problems in the brain cause the mental symptoms. But that is not true in every case. In fact, it's not true for the majority of cases. For most disorders, there is no clearly apparent cause. And that's why they develop talk therapy. You go through and you talk and you delve into the history of the person, and then you can figure out, aha, okay, well, this makes sense now that I know this. For most disorders, therefore, there is no clearly apparent cause. Although we do not wish to reject the disease model out of hand, we question its complete acceptance. We also question whether it is appropriate to place abnormal behavior within the realm of general medicine. And again, it's not always. The Diagnostic and Statistical Manual. The first Diagnostic and Statistical Manual of Mental Disorders was published by the American Psychiatric Association in 1952. It and its two subsequent versions have been accepted by the World Health Organization as the official international classification system and are part of the World Health Organization International Classification of Diseases. So, in 1952, they're like, oh yeah, this is good, this makes sense, so we're going to do that. And I forget what DSM we're on now, but we're past 1 and 2 quite a bit. Clearly, they have proved to be useful. Nevertheless, as Woodruff, Goodwin, and Guz point out, such diagnostic schemas are conventions that may not truly represent anything that exists in nature. They also remind us that there is no guarantee that our present mental or physical illnesses will consist of the same symptoms 100 years from now. And that's because things differ. Like a war veteran's symptoms in the 1940s might not have been the same as war veteran symptoms in the 1990s. So, as things change and grow, it's different for each group. So, depression in the 30s from, subsisting, and depression, from living in the world of, say the 90s, it was a little bit different. So, there's going to be differences when it comes to time and environment and how, that exhibits in the illness. In fact, they believe that as we learn more about diseases, our future descriptions will be so much more accurate that they may not be recognizable to us today. Just like, the humors back in the 1600s, your humors were out of whack. So, that made problems for you. So now, what we believe today in a few hundred more years might, be very simplistic to those people, and might be so more specific that they would be like, these people are crazy, like we said about the people with the humors going on. Excuse me. But the categories will probably be much more effective, because as we learn more, we do better and, pinpoint things better. For now, the DSM occupies a central place in theory and practice, in hospitals and clinics, insurance companies and courtrooms, and, of course, in the study of psychopathology. Why was it necessary to revise Kraepelin's original schema? Indeed, if it was based on something as empirically sound as Kraepelin's system proved to be, why was it necessary to revise it twice in less than 30 years? The answer is poor reliability. And that's because he basically had two mental illnesses he decided were the problems with everyone. And of course, now we know that's not the case. So as they were studying and learning more, they had a quicker, research ability to find out that there are different classifications of mental illnesses and even subcategories of mental illnesses. The problem of reliability. The value of any classification system can be judged by its diagnostic reliability. The likelihood that whatever behavior is exhibited by an individual will be correctly classified. And that's the hope always. Zubin suggested 3 methods to evaluate reliability. Number 1, determine the likelihood that a number of different professionals would give the same diagnosis for the same person at the same time. And that would be called interjudge reliability. Number 2, determine the likelihood that, over time, the diagnosis given to an individual by one or more professionals would hold. And that's called temporal reliability. Number 3, determine the likelihood that, over time, different professionals would classify large comparable groups of people who exhibited the same symptoms into the same categories. We find serious problems in applying the last 2 methods, however. In the second, agreement between initial and subsequent diagnoses requires almost no change in the individual's behavior over time. And of course, as we know, that's not a constant. As the person goes through treatment, they change over time. If the person does not go through treatment, they change over time. So that's not a constant. This does sometimes occur, but certainly not in every case. In the third method, the clinician must assume that the groups of people have been taken from the same population, when in fact they have not been. Therefore, the first evaluation method, finding the interjudge reliability, is really the only practical one. According to any one of these 3 methods, however, the diagnostic reliability of DSM 1 and 2 have been shown to be poor. So back in the 50s, their diagnostic criteria were not as good as they are nowadays. Zubin reviewed several studies of the interjudge reliability of DSM 1 and found that although agreement on major categories was reasonable, there was little agreement on subgroup classifications. For example, 6 out of 10 clinicians might diagnose a patient as schizophrenic, but of those 6, perhaps only 2 would agree on the specific type of schizophrenia exhibited. In another interesting study, comparison was made between diagnoses given by American, British, and Canadian psychiatrists, all using the DSM-2 as adopted by the World Health Organization. After viewing videotapes of the same set of patients, and so we know that was later on because they had videotapes, were asked to diagnose the problems they had seen. As suspected, There was little agreement among the many individual diagnoses, but there was another unexpected result. There were few differences in the diagnoses of psychiatrists grouped by nationality. An instance, in one case, only 2% of the British professionals diagnosed one person as schizophrenic, yet 69% of the American clinicians did so. Canadian groups fell somewhat between the two extremes. This indicates that the culturally different groups of professionals had defined certain behaviors in a similar fashion. And we know here in the good old USA, people are a lot more uptight and worried, about what everybody else is up to and doing and exhibiting. So that makes sense that 69% of us were worried, those providers were worried that this person was schizophrenic, versus 2% of British were like, yeah, they're fine, they're just being weird. And, somewhere in between for Canadians, who are a little more, closer to us than they are the very, blasé British who keep the stiff upper lip and go on with life, and it is what it is. So, well, that's where I'm going to leave you for today. I hope that helped you figure out maybe a little more about why you do what you do. Please like and share this educational program, and that's what this is, an educational program. It is not designed to diagnose or treat any mental illness. If anything in this program triggered you or is a concern for you, feel free to contact your mental health professional and talk about it. Please like and share this. If you want to help me out, subscribe to my YouTube channel. If you want to help me out even more, go to my Patreon page and become a patron. Thanks for watching or listening. That's all for now. Until next time.